Good morning and welcome to the Department of Medicine Grand Rounds. The CME code for today is 25165. And to introduce our speaker is our chief from the Division of Pulmonary and Critical Care Medicine, Dr. Jag Sundram.
Hi, good morning, everybody. It really gives me great pleasure in introducing Dr. Wunsch. Dr. Hannah Wunsch is a distinguished professor and vice chair for research in the Department of Anesthesiology at Weill Cornell Medical Center. Dr. Wunsch trained in anesthesiology and critical care medicine at Columbia University and holds a master's degree in epidemiology from the London School of Hygiene and Tropical Medicine. She had previously held a Canada Research Chair and is currently funded by the NIH and US Department of Defense. Her work focuses on organization and management of critical care services with a particular focus on use of large databases to understand resource utilization and long-term outcomes of critically ill patients. She's the author of the recent book, The Autumn Ghost: How the Battle Against a Polio Epidemic Revolutionized Modern Medical Care. Her grand rounds this morning is the uh, research that she did to bring out this book. It's a real treat, and I've heard her talk at the ATS keynote, and uh, I'm sure you'll all, at the end of this morning, really come back saying it was an incredible talk. The title of this talk is From Polio to COVID-19, Lessons in Ventilation for Our Past. Dr. Wunsch.
Thank you so much. It's a real pleasure to get to join you. Thank you for the invitation. I'm just going to pull up my slides here. Now, I know some of you are thinking, why are we listening to an anesthesiologist this morning? And why are we hearing about polio? And why is this about history, right? And sort of how on earth is any of this going to be relevant to me in my practice? I do promise you that it's a good story that I'm going to share with you. So in that sense, it's just kind of a fun, different kind of grand rounds. But more importantly, I also promise you that there are some take-home clinical messages that really are relevant to all of you if you stick with me through this. And so, and they're not really in my objectives. The objectives, I just sort of kept kind of the standard stuff. So bear with me as I share this with you, and I promise you I will end with some important takeaways. As mentioned, I do have the book, which is a bit of a financial disclosure, and then I have research funding for unrelated work, my regular research, as I call it. So I'm going to start with a quote. As an intern in 1952, we admitted patients with heart attacks wherever bed was available in the medical service, but always as far from the nurse's station as possible, so they would not be disturbed by the commotion, especially the frequent telephone ringing. It was not uncommon for me when arriving on the medical floor at 6 a.m. to draw blood to be sent for testing, to discover that one of my patients had died quietly during the night. Older physicians accepted this as just the way it was. So this is 70 years ago, and this is written by a cardiologist out in California. And, it's really striking for a lot of reasons, but really that sort of that sense of nihilism, right? That there was very little that could be done for people at this time, which is in the lifetime of many people who are still alive. And so what I'm going to share with you is what I think of as an origin story. And turns out humans love origin stories, and Marvel Comics figured this out a long time ago. So we have origin stories like this. How did Captain America turn into Captain America, right? And it's sort of captivating and exciting. And the origin story I was interested in was, how did we get from sort of this nihilistic ward care of where you were just sort of stuck in a corner bed and checked on once in a while, to really modern intensive care. And of course, at the center of that is the ability to provide ventilatory support for people. Obviously became front and center news, COVID-19. Now, this is an evolution of 100 years or more that takes place, and many, many, many changes and advances. But it also turns out that there is kind of one key event, which was a pivotal moment. And that's what I was interested in. Now, the concept of positive and negative pressure ventilation are not new. People have tried for centuries to figure out kind of how to help people to breathe. And this is a one slide summary of, a couple hundred years of experimentation of devices, both positive and negative pressure. And a combination of things kind of was the reason probably that none of them took off. Some of it was our technology just wasn't very good. We didn't really understand physiology that well. And also just not in the right place at the right time, and the ability disseminate information was limited. So there's no one magic reason why this didn't take off then, but it didn't. But I think it's also important to understand why people wanted to help others to breathe better. And it's not the things that we think of like pneumonia. It was really a focus specifically on workplace accidents and resuscitation from things like electrocution, gas poisoning, and drowning that were associated with high-risk work environments. That was a major focus for helping people. And of course, that was not just about the breathing, that was also about the heart most of the time. When it came to surgery, there was, of course, a great interest in helping people to breathe during surgery, in general surgery, but actually more specifically in thoracic surgery, because the ability to do anything in the pleural cavity was limited by the fact that the lung collapsed and somebody stopped breathing and they couldn't do the surgery anymore. So that was also an area of active research. And then when it came to diseases that people were interested in, again, not the kind of classic pneumonia that comes to mind when we think ventilation or ARDS or anything like that. It was really this one disease, polio, that became a focus of respiratory support. Now, I know polio has been in the news quite a bit, unfortunately, but just a quick primer. Polio is an enterovirus, oral fecal transmission. It's actually a lot like COVID-19 in that the majority of people are exposed and have asymptomatic transmission. But for those who did get symptoms, a lot of it was just sort of the non-specific childhood illness symptoms there on the left. A very small proportion, about less than 5%, the virus would leave the gut, go into the bloodstream, and hit the nerves in the spinal cord that affect movement and control of muscles. And so you would get paralysis of limbs. And you would see, this is a poster from the March of Dimes, which was the fundraising arm for what was called the National Foundation for Infantile Paralysis, another name for polio. And you would see commonly kids in braces with limbs that were paralyzed, sometimes temporarily and sometimes permanently. Now, along with, of course, limbs was the potential for paralysis of respiratory muscles. And this came in two forms. One was the spinal form, sort of same mechanism, and it just hit the muscles of respiration. The other was bulbar polio, and that's when it would hit the brainstem and actually take out the nerves that control swallowing and coughing, so that people would literally drown in their secretions. Now, of course, you could also have a combination of the two because polio didn't read the textbook and separate itself out. So often people would have what was called spinobulbar paralysis. But didn't matter what form of respiratory paralysis you had, it was deadly. It was about 90% mortality if you had one of these two forms of respiratory paralysis. Now, that started to change in 1928 when Professor Philip Drinker at Harvard School of Public Health, along with a colleague, Louis Agassiz Shaw Jr., developed the iron lung. And what happened was Philip Drinker was actually interested in that issue of workplace resuscitation. He'd been given a grant to look into it. And he walked by his colleague doing these experiments with a cat. And that actually is a cat there in that photo. And what his colleague, Louis Agassiz Shaw, was doing was measuring basically the size of the breaths of that cat by sealing it in, paralyzing it, and then sucking some air out of the chamber, and that could measure the size of the breath. He was also interested, this is kind of remarkable to me, by the late 1920s, they weren't sure whether mammals could breathe through their skin. So he was also taking samples of the air in that chamber once it was sealed to determine whether there was actually gas exchange going on. And he publishes that in 1928. So sort of remarkable to me that it's been kind of less than 100 years that we've figured that out. But Philip Drinker walked by and realized that this sort of plunger mechanism, that if you kept going, you could actually keep the cat breathing. And they did this for 12 hours to demonstrate that this worked. So again, he wasn't the first person to ever try this, but he tried it at a moment when he then had the technology to build what became the original iron lung. And this is a picture of the first one, which was this tube of metal that sealed somebody in at the neck. And he actually pulled a vacuum motor out of the closet and attached it so that it would suck air out of the chamber and create negative pressure ventilation. Of course, this is probably more commonly what you're used to seeing. They tried this first on an 8-year-old child at Boston Children's Hospital. She died 5 days later, but it was successful in their minds in terms of prolonging her life. They quickly realized they needed things like the ability for nurses to get their hands in there and keep the seal, so they welded portholes onto the iron lungs, and that's why they look like portholes, because they are. And so this was an incredible revolution in care for people who had spinal paralysis, because it decreased the mortality substantially. However, as you might imagine, with bulbar polio and the inability to protect the airway, this was incredibly unsuccessful. It just sucked secretions into the airway, and people died of pneumonia a few days later. So you still had 90% mortality if someone had bulbar polio, but you had much reduced mortality for spinal polio. As you can imagine, nurses hated this, right? Because it's very challenging to take care of someone one of these. A lot of patients were terrified in them. You know, you woke up feeling like you were in a coffin. And they were also very expensive and unwieldy. They weighed 600 pounds. So there were pros and cons to them, but it was this 1928 really represents the first time you've got sort of humans and machines interacting with each other in a way that creates sort of meaningful life support. So off on the side, while this is going on with care of polio patients, Paul Frankener, an ENT surgeon in Sweden, is interested, as I mentioned, they wanted to help develop ventilation for people in the operating room to assist when they were giving anesthesia. And he creates one of the first positive pressure ventilators, the spiropulsator. So rather than the iron lung sucking open the lungs, this actually is what you think of now when we say ventilation, pushing air into the lungs with a positive pressure mechanism. So he experimented with this in Sweden, and there's a caveat that will become important in the story in a little bit. So that in World War II, this is showing you the German Reich in World War II, all in red, all of the countries they invaded. So the first professor of anesthesiology in all of Europe was a man named Torsten Gård. And in the 1940s, he worked in Stockholm, which is white because the Nazis had not invaded, they were neutral. And in Denmark, which is red because the Nazis had invaded, was Ernst Trier Morch, the first anesthesiologist in all of Denmark. So important to understand, anesthesiology as a specialty is very, very young at this point. Trier Morch actually gets permission to cross the Nazi checkpoint into Sweden in 1943 to go to Stockholm and learn about anesthesia techniques from Torsten Gård. He learns about the spiropulsator, this positive pressure ventilator. He takes the knowledge of it back with him to Denmark. He wasn't allowed to take an actual machine with him. He builds his own and starts to experiment with positive pressure ventilation in the operating room there. And then in 1949, he leaves Denmark and goes to the United States. So keep that in mind. As I said, I'll come back to that in a minute. So by 1952, which is the year of that quote and the year I'm interested in, you've got sort of two things happening. You've got some positive pressure ventilators working in a few operating rooms in US, UK, and Sweden. You've got iron lungs being used actually primarily in the US where they had the money to build them and support them, but successfully providing negative pressure ventilation for polio patients. So that's where my story comes in. And it takes place at what's called the Blydam Hospital, which was the infectious disease hospital for all of Copenhagen. And in fact, really much of Denmark is such a small country. And the head of at the Blydam, they did take care of polio patients. And they had 1 iron lung and 6 what were called cuirass respirators. And you can see from the picture there, it's basically kind of like a mini iron lung that's strapped over the chest and provided some support with each breath. But you can imagine is really only useful if someone has a little bit of mild respiratory failure, not particularly effective for complete respiratory failure. And they also had, I always find this one remarkable, what were called rocking beds, where they would strap people's feet in, and the bed would literally flip-flop up and down to use the gravity to affect the diaphragm to improve ventilation. So again, apparently somewhat effective in mild respiratory failure. You can imagine pretty much useless in anything more severe, and looks to me like it'd be horrific to be in one of these and you get nauseated very quickly. But people reported that I actually slept very well in them, which seems bizarre, but was the reality. Now, the man in charge there was a man named Henry Kai Alexander Lassen, and he was this kind of imperious figure who had worked there for many, many years. He was considered a world expert on polio, despite the fact that he'd never had a major epidemic, but he'd seen so much over the years that he was an expert. He'd hosted a world conference on polio in 1951, the year before, and he'd been in charge for a long time there. Now, I said they'd never had a major polio epidemic, and that changed in July and August of 1952 when this started to happen. They were seeing 50 cases a day coming in the door and 10 to 12 per day with respiratory failure. And importantly, the vast majority of those were bulbar failure. Now, also importantly, in the United States, polio was called the summer plague because it would peak in July and August. In the Scandinavian countries further north, and we don't fully understand the epidemiology of this and why, but for whatever reason, polio tended to peak in the autumn. Hence the title of my book, The Autumn Ghost, which was the name some people gave, one writer gave to it in Sweden back in the 1940s. So they knew, as you can see from this graph, we're in July and August. They weren't even at the peak of their epidemic, and they're seeing this many cases coming in. So they were pretty desperate. This is the book in the city archives in Copenhagen from 1952. It's this big black book that actually has all of the deaths they recorded for the hospital in 1952. And as I leafed through it, January and February is meningitis and diphtheria and kind of this potpourri of infectious diseases. And then you get to July and August, and it's just polio, 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 polio. And by that mid-August 1952, they'd lost pretty much that dead on 90% of the patients who had severe respiratory failure. Now, working at the hospital was a young man by the name of Mogens Bjørneboe, and apologies to any Danish speakers in the audience, it doesn't sound like that in Danish. He was actually still in training. He lived on the hospital grounds with his family, and he was actually quite well respected by Henry Lassen, despite being very junior. And he started badgering his boss to invite into the hospital a young anesthesiologist he had recently met. Now, who was it that he was badgering his boss to bring in? It was this man by the name of Bjørn Ibsen. Bjørn Ibsen had started out wanting to be a surgeon, quickly realized that it was a crowded field, and that he was also interested in what he was seeing at the head of the bed. And so he met Ernst Trier Morch, the one anesthesiologist in all of Denmark, who said, well, if you're interested in this, you need to go train elsewhere. You need to go to the UK, or actually preferably the US, where anesthesia as a specialty is more advanced, and get training there. So he had gone to Mass General Hospital in 1949 and trained under Henry Beecher there. And he learned anesthesia, but he found it incredibly eye-opening. He said, later he sort of wrote about it, he said, at conferences, the young American doctors expressed themselves freely and without inhibitions. I began to understand here that I was among doctors who thought differently and along other lines than those I was familiar with. He described it as a lot less hierarchical, which I find ironic, because if you want me to describe Mass General Hospital and Harvard Medical School in the 1950s, I would have guessed it was extremely hierarchical. So I think that tells you really how bad it was in the European system, that he viewed this as a kind of free, open system. And he also described how at first he thought there were more complications for the patients having surgery, but then he realized that it was actually just the fact that they talked about the complications to try to learn from and improve their care, and that this was a novel concept to him. Now, Lassen was not particularly excited to invite in this young anesthesiologist he'd never heard of, and Mogens Bjørneboe couldn't really articulate what Ibsen might offer. He had just been impressed, and there's a whole backstory to how the two of them had met, which is detailed in my book, but he'd been impressed by this guy and thought, you know, as he said about the Americans, that he kind of thought outside the box. Finally, on August 25th, 1952, with nothing else to try, he invited Ibsen to the hospital, and they met in his office with about 20 other people. And Lassen said to Ibsen, what do you know about the care of polio patients? Ibsen had to acknowledge, you know, he was an anesthesiologist. He'd never taken care of a polio patient in his life. And now this is where I think Lassen deserves a lot of credit. Many people would have said, you've got nothing to offer then. I don't know why we're talking, kind of get on your way. Instead, he said, I'll take you on a tour of the hospital. I'll show you what these patients look like. As they toured, Ibsen noted a constellation of symptoms: hypertension, tachycardia, twitching, confusion, and clammy skin in all the patients that were very close to death. And he asked Lassen about this, who said, this is end-stage polio. The virus has invaded the brain and the kidneys. It's shutting down the body. There's nothing you can do to reverse this at this point. Ibsen looked at these same symptoms and said, actually, I think this is just carbon dioxide retention. Now, why did he say that? I mean, from the perspective 70 years later, it's like, why wouldn't you say that if you know people are struggling to breathe? That's pretty obvious. You have to understand that this was not thought about. They didn't understand respiratory physiology at the bedside. And Ibsen had weirdly, they tapped the right man in the world. He'd been playing around in the operating room with this giant device called the Brinkmann Carbovisor. He was studying end-tidal carbon dioxide. That's what this measured. And in the operating room, he would sit there and bag his patient down and watch the end-tidal drop and then stop breathing for a while. And of course, when he bagged them again, the end-tidal was high. And he looked at the symptoms of his patients at the time and recognized the same symptoms in the patients on the polio ward. He, in fact, published a paper that very year, and it must have been nice to do research in 1952. It's literally like end-tidal carbon dioxide tracings in the operating room and in healthy patients. That's what he was studying. So he knew what he was seeing. And what did he propose, therefore? He proposed to do what they would do in the operating room, a tracheostomy for a more secure airway, given where these patients were, and then positive pressure ventilation, which they'd used routinely in the operating room, but really was radical. And I think it's, again, important to understand this was not used outside the operating room. Except Ibsen knew it had been tried outside the operating room. And with him, he had an obscure paper he'd come across. And he actually had a copy with him from the Annals of Western Medicine and Surgery. And in it, Albert Bauer and V. Ray Bennett, in a polio epidemic in Los Angeles in 1949, reported on their care. And they too were seeing massive amounts of bulbar polio. Now, the difference was they had access to a lot of iron lungs, but they also quickly discovered that having iron lungs didn't help in that situation. And so what they did is they created what they called the Bennett positive pressure respirator attachment. You can see there is a trach there, and this just little tube that connects to it that provided positive pressure ventilation. And they reported a reduction in mortality for these patients from 90% to 20% in that epidemic. Now, crucially, Ibsen recognized that you can see here, this patient's also in an iron lung. They were providing positive pressure in combination with negative pressure ventilation. And what Ibsen realized, was that you didn't need the negative pressure ventilation if you had that positive pressure component. So he recognized that all you needed was this very simple anesthesia device called a Waters to and fro circuit that they use in the operating room, which you can see is a bag to squeeze, soda lime to scavenge the exhaled carbon dioxide, an oxygen tank, and some sort of cuff tube, either endotracheal or trach. So Lassen apparently was not particularly convinced by this description and explanation, but with nothing else to try, he said, okay, I'm gonna let you try this on one patient to demonstrate it, and I will choose that patient. So the very next day, on August 26th, a little girl by the name of Vivi Ebert was admitted to the hospital. She lived in this house in Copenhagen with her family. She was about 12 years old at the time. She's about 9 in this photo here. And she had classic bulbar polio. 90% mortality, pretty much 100% mortality, given how sick she was. And by the next morning, August 27th, she was already dying. She was in extremis, struggling to breathe. Lassen and his team rounded on her and said, right, kind of nothing to lose, let's try it on her. So they brought in Ibsen, they brought in an ENT surgeon, they bundled her mother out of the room. Apparently there was no informed consent going on at that point. And a bunch of people piled in to watch, and the ENT surgeon did a trach, and then he handed over care to Ibsen. And we actually have the minute-to-minute record that he kept on that day. And one thing, he was worried that he gave her general anesthesia for the ENT procedure, that she might arrest and die. She was so close to cardiovascular collapse. So they did the trach under local anesthesia, but it's technically a little more challenging, and they got into some bleeding. So when Ibsen took over care, she had blood in her airway and she went into bronchospasm. And he couldn't ventilate her. And he wrote, now in a situation where we cannot perform ventilation because of her spasms and agitation. Apparently everyone left the room to go to lunch. They didn't want to see a little girl die. Lassen patted him on the back and supposedly said, if she's like this when I return from lunch, you need to stop what you're doing and just let her die. So Ibsen knew he needed to break the bronchospasm, and he only had one way to do it. So he took a risk, and he wrote, we administer pentothal 100 milligrams. And he got lucky. Her blood pressure held, she relaxed, and he was able to ventilate her. And he wrote, about 15 minutes later at 1:32 p.m., the patient is immediately warm and dry. And from there on, she woke up, she was pink, he was able to keep bagging her. Everybody came back from lunch, and I hate what I call the M word in the ICU where I work, the miracle that can happen. But in this case, this would have seemed like a true miracle. They knew the natural history of this disease, and it was that she would be dead by the afternoon. Instead, they saw her awake and alert and pink. They stayed with her through the night, 3 different doctors hand ventilating her to prove that they could continue to do this and keep her stable. They also gave her some blood and some glucose and things like that. And by morning, it was very clear that this worked. And Lassen knew a good thing when he saw it. And he said, right, we're going to do this to every patient. However, as I mentioned, there were no ventilators in all of Denmark. Ernst Trier March was the only person in Denmark who actually knew the technology for ventilators, and he had taken that information with him in 1949 when he moved to the United States. So without ventilators to hook patients up to, they turned to the medical students of Copenhagen, and they called on them, went over to the medical school and said they were needed, and they came first in the dozens and then in the hundreds, and ultimately 1,200 medical and dental students sat at the bedside in 6 to 8 hour shifts and ventilating these patients 24 hours a day to keep them alive. And, of course, these patients were awake. A lot of these students had never touched a patient before. They didn't understand respiratory physiology. Even the senior doctors didn't. They were given 5 minutes tutorial on how to do this and then basically told, go, keep them alive. And they got to know the patients very well, as you might imagine. They read to them, they told them stories, and at the same time, they were hand ventilating them the entire time. I actually had the privilege of meeting a couple of these medical students. This was Anne Holton Jensen. Unfortunately, she died soon after I met her, but she was incredibly proud of what she'd done taking care of these patients and became an anesthesiologist because of it. In fact, she named one of her children after one of the patients she cared for. We actually have some footage from the epidemic, so you can see what it looked like. And one thing to note is these are what we would consider true anesthesia bags. These are not ambu bags that spring back as soon as you squeeze them. This requires the flow of gas to reinflate them. And so that can be very scary because any kink in the system, running out of oxygen, anything like that, you actually lose the ability to ventilate. And so my book details, a lot of the complications. They were kind of learning on the fly. Of course, they had to feed them. A lot of the time they did put in a feeding tube, and their mechanism would just be to blend up whatever the meal of the day was and stick it down a feeding tube. That was the best they could do. So another thing that happened during this epidemic is there was an argument over what was going on in the blood in these patients, and were they acidotic or were they alcoholic? And it turned out they had no measurement for pH in the hospital. The one thing they could measure what was called total bicarbonate using what was the Van Slyke method. It was a machine to measure this in the blood. And they would measure the blood on other patients, and they might have, a very low total bicarbonate. And so they would say, okay, this patient has a metabolic acidosis. Therefore, if the patient had a very high bicarbonate, they said this patient must have a metabolic alkalosis. When they measured the blood of the patients with polio, it was a high total bicarbonate, and that's because it included carbon dioxide in the measurement. And as I mentioned, they just didn't know or think about carbon dioxide. So if you ask them, they would say patients dying of polio by extrapolation must have a very high pH in their blood with this metabolic alkalosis. Of course, Ibsen looked at these patients. He said, no, there's a lot of carbon dioxide in their blood. If you could measure it, you would see that they have a metabolic acidosis, and their CO2 is very high and their pH is very low. There was one man in the room that day in Lassen's office who said it was like a light bulb going off. His name was Paul Astrup. He was the head of their laboratory. And he later said, we just didn't think about carbon dioxide. And as soon as it was explained to him by Ibsen, he wanted to test this. Now, as I mentioned, there was no blood gas analysis. He had no pH monitor, but he knew somebody who he thought might be able to help. And that was the Carlsberg Brewery and the company called Radiometer AS, who had built a pH monitor to measure the pH of their beer down the street. And so he called them up and he said, can I borrow one of your pH monitors? And they said, sure. And it turned out it worked on blood as well as beer. And he was able to measure the pH of a child very near death in the hospital. And of course, as expected, it was incredibly acidotic. He recognized in that moment that this was essential information and that you needed to triangulate this total bicarbonate with the pH to actually understand what was going on in the body and to understand the effect of respiratory status. And so he creates the very first blood gas analysis system in the world to, in real time, provide information at the bedside to help with ventilation. And he writes later, by January 1st, 1953, they'd done 705 determinations of pH from patients with threatened or manifest respiratory paralysis to guide care. So this is the start of blood gas analysis as we know it. And in fact, through much of Scandinavian countries for many, many, many years, if you wanted a blood gas, you would actually ask for an asterisk. That's what they would call it. So their intervention was incredibly successful. They went from 87% mortality to, in the middle of the epidemic, down to about 36% mortality for these patients, and by the end, down to about 11% mortality. Really unbelievable numbers, right, from our perspective of any intervention we try to do, where we're excited if we get like a 2% reduction in mortality in modern interventions. So really extraordinary results. And they also recognized they needed something other than the students, so they brought in what they literally called mechanical students to take over as people started to develop ventilators, both in Denmark, and then they brought some down from Sweden where they already existed. And you get this explosion in ventilator development that comes out of this, and they ease out the students. Now, I think it's important to note, not all the patients were happy to be hooked up to a machine like this. You know, there were downsides of students. They didn't always give the same size breath, and they could, in theory, fall asleep or, you know, have some other problem. But they were a reassuring presence at the bedside, and suddenly these patients lost that. And I think that's important to acknowledge, that there are downsides of sort of this movement towards technology. I also want to acknowledge that even embedded in that 11%, that not all survive, right? That, you know, even as they improved things, it was a lot of deaths, and it was a lot of deaths often of children who they got to know. And one of the students who was interviewed, not by me, he was dead by the time I was writing this, but by someone else who spoke with him earlier, described the struggle of going back to school once they, you know, after months of being in the hospital doing this work and knowing how important it was, and feeling in a fog and being unable to really function or focus. And he described going on a skiing holiday to try to sort of get out of this funk. And he was off on his own. And this is his description from that time. He said he was eating communal meals where he was staying. He said, "I said little during the meal, concentrating on eating. I would occasionally return conversation, but rarely took the lead. As the dessert was served, one of the other guests unexpectedly cracked a bawdy joke. After a momentary embarrassed pause, all in the room roared with laughter, none more so than myself. It seemed that a safety valve had opened, and suddenly I felt able to cast off my reserve. But as I laughed, the tears started to flow, and the laughs slowly changed into cries, heart-wrenching, soulful wails. At first unnoticed, gradually one by one, the diners stopped laughing until the whole table went silent and stared at me, their mouths open. I buried my head in my hands, and at last the cries and mourning and tears for the children came." And I always try to put this in talks to medical community because I think it speaks to a lot of people's experience dealing with the aftermath of COVID. There's a lot of parallels here. I think it speaks to the fact that humans have struggled with that type of exposure and experience, obviously, you know, for many, many, many decades. I hope that we have gotten better at acknowledging it and providing support for people. But I do think it's, you know, as we sort of, I celebrate this story as a positive, happy, incredible advancement story, that there is always this dark side, and that there are people who, you know, whose lives are altered in not good ways by it as well. However, Lawson recognized the importance of what they'd done, and that this was a huge advancement in care, and the world needed to know about it. And so in 1953, early 1953, he publishes a paper about their experience in the Lancet. I mean, the epidemic wasn't even over. For those of you who are more academic minded, you will note there is one author on this paper. He was not inclined to give credit for what they had done to anybody else. And this became a major point of contention between him and Ibsen later in life. Interesting, Mogens Bjørneboe, who's the one who recognized Ibsen might have something to offer, is kind of nowhere in this fight. He sort of wanted no part of it. This became a issue later. But Lassen was very successful in helping people around the world to know what they had done, and really did get this disseminated. Now, Ibsen did not get the job as the professor at the new professor at the university hospital that he'd wanted, and there's a whole story to that. But instead, he went to the municipal hospital, basically the community hospital down the street, where he was kind of given carte blanche to do what he wanted as the first anesthesiologist there. And what he wanted to do was to take his vision of what could be achieved from what he'd seen in the polio epidemic. And what that meant was, in these windows here, he starts what I consider the first modern intensive care unit in the world. Now, why do I say that? Well, from what he learned in the polio epidemic is all that's in red: a dedicated area for care, 24/7 staffing, blood gas analysis, invasive mechanical ventilation, and specialized nursing. He recognized all of those were key when someone was this sick. He also knew about other organ support and resuscitation and frequency of vitals and monitoring from his care of patients in the operating room, and he implemented that. And then this is the last crucial step that is really his vision. He recognized that you could use this type of support not just for polio patients, but for anyone who sort of met these criteria of being critically ill, and in particular needing respiratory support. So in December 1953, he admits his first non-polio medical patient from the ward. And that's why I consider it the first modern ICU. I think it's worth pausing just to sort of think about, what did it take for an innovation like this to occur? And there's some things that, like, we don't try to reproduce, we wouldn't want to reproduce, but I think we have to acknowledge, which is desperation. There were a lot of coincidences in terms of people meeting, how they met, who knew what. I detail them in the book. They're kind of fascinating and sort of kind of pulling that apart. But obviously we can't reproduce that. There's a lot of luck, what I call the N of one experiment. I think that obviously positive pressure ventilation would exist even if Ibsen hadn't developed it then, but it would have been set back if Vivi Ebert had died, and of course they hadn't done this for all these patients. And there's also lax oversight, right? They didn't have to go to an IRB, they didn't have to get permission from family to try this. Very, very different world. There are some things I think we can learn from. I think exposure to another system of care. Ibsen going to the US and feeling like he learned how to think differently about things, having a different exposure to medical care. And this is where I always urge anyone who's a trainee in the audience, or even if you're not a trainee, go spend some time in a different country. The US medical training system makes it very hard to actually spend time somewhere else. We don't have that kind of built into our culture of, you should go spend 6 months in another country and learn care there. So I would say, even if it's just a day to round on a ward or an ICU or be in a clinic, it's so eye-opening to see how different people do it in different countries. Willingness to break down the hierarchy. Lassen becomes a little bit of a kind of enemy and villain towards the end with his credit issue, but in the key moment, he was willing to listen to someone who knew nothing about polio. Ibsen did have the courage to speak up, and the courage of his convictions to say he thought this would work. I do want to acknowledge they also had financial support to make this happen once Lassen recognized that this was the way forward, and the city of Copenhagen basically gave him a blank check. And then I think this goes along with exposure to another system of care, but is slightly different, which is alternative perspective, right? Ibsen didn't know anything about polio. But because of that, he didn't have this received wisdom of what was going on in these patients dying of polio. He hadn't been indoctrinated. And I think this really, in this current climate in particular, is important to say, speaks the importance of inclusivity and diversity on teams, medical teams, research teams, administrative teams, because you actually never know who's going to have that kind of different perspective and idea that's actually going to make something happen. So these ideas do diffuse to North America. 1958, you see the first modern ICUs in these countries: Peter Safar in Baltimore, Max Harry Weill in Los Angeles, and Barry Fairley up in Toronto. Amazingly, Barry Fairley is still alive. He lives out in San Diego, and I still correspond with him a bit. And he's written a really nice piece about what it was like in that first ICU in Toronto, and how much the Wild West it was, right? They were making alarms to put in line in the ventilators because they realized they were having deaths deaths because a nurse would turn around and the ventilator would disconnect and there was nobody knew, they couldn't hear it. And so things like that, just these really basic concepts. But importantly, Peter Safar in his autobiography writes, we knew what they'd done at the Bly Dam, and that was really important for them moving forward with setting up these units, that they had this understanding of the importance of this experience. And you get this massive explosion in ventilator development, as well as the development of the ICUs themselves. Some of you may have used these devices, but really this becomes a kind of new era of respiratory physiology and respirator management. And it's really kind of hop, skip, and a jump to what we then consider a modern ICU in terms of what we're doing. And really at the core of the care, particularly during things like COVID-19, which is, primarily, well, really purely respiratory, it was just the same management that Ibsen was offering to his patients back in 1953 when he starts that first ICU. So what is the future? Well, I think what's interesting is to think about the fact that we possibly could have some move back to negative pressure ventilation. This is now an older paper from 2008, but speaks to the fact that there is research into negative pressure ventilation, and this is done on rabbits in iron, like mini iron lungs. And I think that, like here we are doing rabbit iron lung research 100 years after they're doing cat iron lung research. But one thing it shows is that the damage to the lungs in these rabbits getting negative pressure ventilation is less than with positive pressure ventilation. So although we've swung kind of fully over to positive pressure ventilation, I think there is the potential for us to, in certain circumstances, start using negative pressure ventilation again. Obviously not with a full-on 1950s iron lung, but with more modern devices, and they do exist. So I wouldn't be surprised if in sort of 10 years time for select patients this becomes an option for care across many ICUs. So when we think about the legacy of polio itself, I think most people, you hear the word polio, you think vaccine. That's a lot of what's been in the news recently. But I hope I've shown you that ventilators, blood gas analysis, respiratory physiology, and ICUs really all spring from the need to care for these polio patients, and a lot of it from this one epidemic in particular. I do want to acknowledge a few other things that we've learned from polio. One is about rehabilitation medicine, although world wars were certainly important. But a lot of what we know about how best to rehabilitate individuals with physical disability comes from the need to support polio survivors. Disability rights and the fight for disability rights, a lot of that was the early polio survivors who were very vocal and articulate. And then also the long-term sequelae of viruses. And I want to talk briefly about that. Before I get to that, though, I do want to acknowledge the vaccine, right? This is the headline in 1955 when the Salk vaccine comes out. And, if you talk to people from that era, a lot of them who were children will describe that, their parents just broke down in tears, crying when they heard the news that there was a polio vaccine. It was just, I think it's hard, or maybe not so hard with what we went through with COVID, but to understand the fear for children with polio, even though it didn't, at the end of the day, attack that large a portion of the population. This idea of this kind of lurking disease that might fell your child and cause them to spend the rest of their life in a wheelchair with nothing you could do to stop it or reverse that was terrifying. And so really huge when this came out. And if we ever need an advertisement for vaccination, which we do need right now, this is it. This is cases in blue of polio in the United States in the 20th century. And you can see you get to about 1955 and it just starts to plummet. Now, there was one case in the United States a few years ago in New York, as many of you probably know. Just to put that in context, that was derived from the Sabin oral vaccine that is being used in parts of the world where it's not fully eradicated. And like 1 in a million or even less now, it can mutate back. It's a live attenuated virus. And it mutated back in someone who'd received the vaccine, who then traveled to a part of New York where they were unvaccinated. And so it was an adult who was unvaccinated who got it, not from circulating polio in our community, but from the vaccine-derived form of polio. But this is an incredible accomplishment. The fact that I'm guessing there was no one on this call who was taking care of an acute case of polio. Possibly if you worked in other countries, that is not the case, or you have. But I want to end by talking about post-polio syndrome, because this is something that, unless you're in adolescent medicine, is something that you should be aware of. It was first described in 1875 as a report, and it is symptoms such as weakness, fatigue, pain, and functional loss that starts at least 15 years after someone had polio. And it can occur in people who had full recovery from paralysis. So they may be leading totally normal, functional lives, and they start to develop this new weakness. Often it's in the limb that was affected originally, but it can also be in limbs that were not affected originally as well. And it's a diagnosis of exclusion. So it can be hard to recognize whether this is aging, as a lot of these are older people now, or whether this is truly something more than that. The estimates of it are anywhere from 20 to 80%. My feeling is it's probably on the higher end, but we don't have good data and estimates really, because it's so hard to determine what's the underlying population at risk. A lot of people don't talk about polio, won't share that they had polio, don't realize it's important to mention it. So it's very hard to pinpoint. There's a couple theories about this. When polio hits, it takes out the motor neurons. And as people recover, if they get any recovery of movement and muscles, it's because the other motor neurons grow bigger and take over the motor unit that has the dead motor neuron. And so there are a few theories. One is reactivation of polio, which has kind of been debunked because it hasn't ever been well isolated consistently in people this far out. An autoimmune reaction is possible, but really the biggest theory is that this is a metabolic fatigue of the remaining motor neuron units, and that over time they just can't keep up. I always think of sort of Audrey from Little Shop of Horrors getting bigger and bigger and sort of saying, feed me. And so that's the theory. And so the idea is that people could have had damage to limbs where they didn't show any overt paralysis as a child, but then later in life, without knowing it, they do have damage, and that's manifesting. There is a review article now back in 2000 on the characteristics of managing post-polio syndrome. We've just written in the British Journal of Anesthesia a review of anesthetic management of these patients. It's one of their big concerns. And I'm personally haunted by the idea of, what patients in the ICU who say we're struggling to come off a ventilator, was this actually post-polio syndrome that was manifesting? And we just don't ask, right? It's just not on anyone's radar to say, is this new weakness you're having? Is this difficulty with your left leg that you're having? Could this be due to polio? We often sort of dismiss it as aging. And these patients will be so grateful to you if you take seriously their concerns and you acknowledge what they've been through, and even ask if they've had polio, because a lot of them have been taught over the years not to talk about having had the disease. And so they don't even know to mention it as something that might be relevant to their current care. This is a map of Copenhagen from 1952, and it was actually in the background of that picture of Henry Lawson at the beginning of this talk. He sent out medical students to track every single case of polio in the city that year. And if it's blown up, you can see he put a pin in the spot of every case. And they were trying to understand the pattern of these cases, and they didn't really get anywhere with that. But it is an incredible historical document of these cases. And I want to acknowledge that all of these pins are individuals. These are some of those individuals from 1952. Some of them actually found their pin for me on the map. All of them were in the epidemic. All of them had paralytic polio, and all of them actually have post-polio syndrome, which is why my bias is that it probably affects the majority of people, if not all, who have had paralytic polio. Their stories are in my book, really kind of bring to life the experience. And in fact, now when I talk to more lay audiences, this is the piece of my book that I really emphasize, because we have to help people to remember the catastrophic effects of polio on people and why they should care about vaccinating and why that is so important. And I do think it's through stories like theirs, to understand how their lives were altered by polio, that we have the best chance of helping people to understand that. I'm going to end with just one last film. This is Blijdam's Hospitalet. This is the Blijdam Hospital in the summer after the epidemic. And there's sort of 2 points I want to make here. One, I find it extraordinary. Ventilators have barely been invented, and yet the humanity of recognizing that they needed to get their patients out in the sunshine, right? Something that we still struggle with. Now, they do things that I wouldn't recommend here, that I think we have improved our care, that we're not blowing our patients up, letting them smoke. I found this extraordinary. And I do think that it is amazing that 70 years later, we have patients who are on ventilators, where the idea of getting them out into a courtyard, into the sunshine, into a garden while they're in the hospital is something that we really struggle to do. And so I would encourage, particularly those of you who work in ICUs, but on the wards, that sort of sense of humanity, and to remember that. And then this little boy here, when he gets closer, you'll see he does have a trach. He's been ventilated at some time, and you can see his arms are still paralyzed. That hasn't recovered, and he's in those 2 slings. This is the little boy who's always stayed with me at the bedside. Why? Because nobody can take away that paralysis, right? They can't reverse that. But someone took the time to try to make this just slightly less horrible by pinning those little sheriff's badges on him and giving him sort of, that sense of something positive. It's a tiny thing, and yet that's what keeps me at the bedside thinking, what can I do for this patient? Is it a cup of coffee? Is it another blanket? Is it lingering 1 more minute to ask whether they have another question, right? Because at the end of the day, with all this new technology, all this machinery that I'm celebrating this talk, the end of the day, it's actually those things that our patients and families will thank us most for, and will be the things they remember about their experience of illness that will make it bearable. So when I said there was a sort of, message for everybody in terms of patient care, that's actually it, is to don't forget that it is the small things that even in our modern era that really make the difference in the care we provide, and no AI, no technology can ever change that. So I'm going to stop there to leave a few minutes for questions. This is my book. It actually just came out in paperback last week. And so it is written for the general public. I want to note that. It's written to not be annoying to you if you want to read it, so that you can enjoy it too. But I definitely wrote it so that it could be shared with people who are not in medicine, for them to really fully appreciate and understand this story, and be appreciative of modern medical care and everything we do every day. So I also want to acknowledge the second half of my dedication for all those who have ever held a life in their hands. I realize that is all of you on this call today. And so really this book is dedicated to everyone here. So thank you so much for the opportunity to share this with you. And I'll stop there and take some questions.
Thank you so much, Hannah. That was, as as I mentioned when I introduced you, this is not the first time I'm hearing this, but even now I have goosebumps. It's
Thank you for listening
incredible.
again.
Thank you so much. What a wonderful talk. Let's see. So I'm trying to get through the chat here to see if we have
I think
any.
there's one raised hand I see, actually.
Oh, okay. Go ahead. I think you can.
Right. Good morning. I agree. Thanks so much for a fabulous, really fascinating talk. I think as we get older, we appreciate history more, but this was really, really great. It's not really a question, but I want to highlight sort of 2 things that you alluded to, because I think they're key, and I really agree. One was your comment about getting alternative perspectives. And while I don't think going and spending 6 months in another country is feasible, as you sort of alluded to, I would encourage people to think about, going to talks and reading papers outside your field like this, hearing from anesthesia or hearing from other things. I think going to conferences and networking with people from other countries is useful. I think for trainees, using your electives that way a little bit. It's not going to be 6 months, but maybe it's 2 weeks or 4 weeks, visiting professor things. I think it's critical that we have this crosstalk, and really in academic medicine, we're fortunate that we have opportunities to do that. So I would encourage that. And then the other thing you were talking a little bit at the beginning before we started, but you alluded to, is really this need for us to inform the public about the need to support and continue research funding, because, given all of the other regulations, we can't just experiment, willy-nilly. We have to have support for time to submit our IRBs and get through all of the paperwork and that sort of stuff. And I don't think this is a great story about how that experimentation and research, the head of Francis Collins gave a talk about NHLBI and how all this has done. But I think we do need to be in this time emphasizing the need that we need some structure that supports research so we can continue these advances. Anyway, thanks so much.
Yeah, absolutely. And to your point about, 6 months is not feasible, but, often I'll just drop in for a day. Sometimes when I have the opportunity to travel a fair amount for work, but even a day is eye-opening. You learn so much just seeing the structure of a team, how they do handover. I mean, I was actually when I was visiting Copenhagen and was taken into the ICU for a day, they had a harpist outside some of the rooms. And, just the idea of like, oh, wow, they actually really do music therapy here, and I just found it so interesting to see the different approaches, how nurses are integrated differently into teams, often very different in terms of how they're interacting. And so, so I think that it's very much doable if you sort of take that perspective of any opportunity that comes along, and you do learn a lot.
Thank you. Thanks, Dr. Clark. Dr. Clark's our chair of medicine. Julie, you had something you wanted to share? Oh, she did put it into her.
Yeah, I'm sorry. Hi, I'm Julie Grimes. I loved your story. You can see it in the chat. I'm still reminded of my aunt who's 86 years old, who only retired about 10 years or 50 years as a medical technologist. But she recalls, this is in Quincy, Illinois, for 2 summers in a row, kids could only play in plastic pools in their backyard and not in any contact with any other kids because they didn't want to get ill. But the irony, it was definitely age specific, because my mom at age 90, it wasn't for her. It was a certain age of kids that across the towns, the kids spent 2 subsequent summers just in their backyard in a plastic pool because they couldn't interact because nobody wanted to have polio. And so she took that on as a choice that she wanted in some capacity to be involved with medical care to improve lives. So, she brought that story up during COVID because we did family Zoom across the country and shared stories. It brings back all kinds of memories of aunts and uncles who lost their limbs and were in iron lungs.
Yeah.
So thank you for this wonderful talk. It brought back.
No, thanks for that. Yeah, I do think that one thing you learn is that many people have a connection to polio in their family of some sort. And it is only when you bring it up and start asking that you learn this. I went many years in medicine, sort of nobody talked about polio, nobody mentioned their family member with polio to me. And as soon as I started talking about the book, there's always people who say their mother died of polio, they had an aunt with polio, and just how it affected them. And so I do encourage everybody to just sort of be aware of it, because it's there and they really were taught never to speak of it for this long period of time. It's been surfacing. I think there's another question in the chat. Can you comment on mechanical ventilation, new situation of ventilating the obese patient? When our MV history is ventilating thin, frailer patients, did you learn anything? Yeah. Well, interesting. There's a meta-analysis that just came out of prone positioning in awake non-ventilated patients or people on high flow, which does show, I'll be honest, I have not looked at the details of the paper, but it's done by a group that is mechanistically excellent and statistically excellent. So they did find a benefit to that. And I think that given your comment about, the challenges of obesity and specifically positive pressure ventilation, that having other approaches, such as we learned in COVID, not just for those who are obese, but for everybody, but maybe particularly to benefit those who are obese, is the fact that we can do things like prone positioning that may help in situations like that. It is interesting to think about, would those patients benefit in some ways the most from negative pressure ventilation as another approach? Some challenges there also in terms of just the mechanics of that, and having devices that are the right size and such. But I do think there are opportunities. Obviously, anything where you need to protect the airway, the negative pressure ventilation by itself is not going to be adequate. But it may be an alternative, particularly when you you've got someone with sort of tiring muscles, and that's the main issue. So, I don't have anything more beyond that to say about obesity in COVID-19. I think that was a complex relationship between obesity, the virus, and mechanical and respiratory mechanics. But hopefully we have learned something in that regard.
I think, yeah, it's
Time.
it's time. So thank you so much, Hannah. I mean, like I said, incredible talk. Thank you for sharing.
Thanks for having me, and have a good rest of the week. Thanks so much
Thank
for
you.
everything you do. Bye-bye.
Bye now.